Thank you. Good evening, friends. Today we are learning with the concept of sagittal plane deformity with using navigation, why it is important and
Good
how
evening, sir.
sagittal. Yeah, good evening, Dr. Ripendra. Uh,
Uh, uh,
we are starting with this session of sagittal plane deformity using navigation. Okay.
okay, sir. Sure, sir.
Uh, I will start this session. It was past 8:05, so that's the reason. And Dr. Shravan has confirmed my audio visual is right. So let us start. So why this is important? Why this sagittal plane deformity is important? Dr. Shravan, can you tell me what is the FFD for this case? Can you quantify this, Dr. Abhishek or Shravan?
Just by clinically looking, we can approximately we can say
Yeah, approximately you can tell me how much could be this
max.
angle?
It could be 60 degrees.
It could be 60 degrees. Yes. Any other guesses? Dr. Abhishek is here.
So 30 degrees approx.
Okay, 30 degrees. Okay, fine. So if I say this is his knee now, so what is his FFD now?
Now 0 degrees.
0, sir.
0 degree. So exactly this is what happens on table. Most of us might have noticed when we put tourniquet around thigh, we tend to get that false FFD sometimes, especially if the thigh is bulky. Patients of obesity around the thighs. Okay, there are different types of obesities. Obesity predominantly around the thigh, and you inflated the tourniquet. You try to get this kind of picture. Okay, and sometimes if there is an associated FFD of the hip, most of the times when you see FFD, okay, it's osteoarthritis. Okay, sometimes there are conditions where we do have inflammatory arthritis of the hip also, right? Like in case of rheumatoid arthritis. So where we have FFD of the hip, okay, FFD of the hip and FFD of the knee. So in this situation, it is very difficult for us to clinically quantify how much the FFD of the knee is. Okay, so that's very important to how much can we quantify the knee. So why knee FFD is important? Because we all know that the pre-op FFD, okay, has got a risk factor for a post-op FFD and range of motion. Okay, the patient is having 15 degree of FFD. We tend to keep about 5 or 10 degrees of FFD post-surgery if the FFD is not treated properly. Okay, but why this FFD is important? How FFD will have an effect on walking? Any guesses? Any suggested answers? Any thoughts on this? How FFD will have an effect on walking, Dr. Shravan?
So the axis will not be aligned. Mechanical axis will not be aligned.
This
Okay, mechanical access. No, okay, fine. Mechanical. Okay,
gait
we'll
will
go.
have an effect on gaits.
Okay, will have an effect on gait. Yes, will have an effect on axis. What axis you're talking about, Dr. Abhishek?
So the correction which we want, sir, of that mechanical axis, or what we're aiming
So
for in this.
mechanical axis. Okay, if mechanical axis is not A, we got. So what will lead to? If you don't achieve this mechanical axis, what will lead to?
Patient will still not be having pain-free walking.
Yeah. So patient will have again some discomfort or pain, or chances of that early loosening of processes can happen. Okay. So why this pain? Even the pain has gone, sometimes even discomfort can be there. Okay. So all these reasons. So there are few things which I also want to add. First thing is because of FFD, there is increased quadriceps action. Okay, the quadriceps is continuously activated, and since the quadriceps is continuously activated, it leads to early fatigue. Once the muscle gets its fatigueness, there is chances of periprosthetic fracture, especially supracondylar part or metaphyseal region where you have the least strength of the bone. Okay, the bone quality is very poor there. Metadiaphyseal junction, there you sustain a fracture. Okay, if at all, if you put a stem or something, you have a fracture around the periprosthetic region, that's on the shaft or even the subtrochanteric neck region. Okay, so when the muscle loses its tension, that muscle loses tension because of fatigueness. Okay, second thing is, if there is an FFD, there is increased periprosthetic joint action, patellofemoral joint action, which will lead to constant anterior knee pain. Okay, constant anterior knee pain. Sometimes the patella will be hitching onto your poly insert. Okay, it will be start inserting onto the poly anteriorly, it start hitching into the poly liner of your or the tibial tray. Okay, sometimes there is increased stress on the posterior condyles of the femur and posterior tibial condyles. Posterior part of the tibial condyle, there will be increased stress. When the FFD reaches about 15 degrees, there is no heel strike happening for the patient. When the FFD is more than 15 degrees, say call about 20 degrees or 30 degrees, the patient walks on toes. So this will lead to gait abnormality. All this will lead to, as Dr. Abhishek said, the alignment is not correct. So early loosening, chances of periprosthetic fracture, okay, increase fatigueness, increase polywear of the posterior part of the tibial surfaces, where your poly has been kept on the posterior part, and on the patellofemoral joint. If the patellofemoral joint is not replaced, then the chances of pain, anterior knee pain, is very high. Okay, so all these are the factors of having an post-TKR FFD. Okay, so what is the risk factor for the post-TKR FFD? Pre of FFD. So that is why to accurately assessment of FFD is very important while doing a TKR surgery. Hence, the role of navigation is important. Okay, so before moving on to this, just want to have a quick revise on what is the cut which have an effect on extension gap, because when extension is not achieved, when FFD means what? Full extension not possible. Full extension not possible. So what are the cuts which have an effect on extension gap? We all know that.
Distal femur.
Yes,
Distal
yes,
femur, tibial.
distal femur and the tibial cut. Okay, so this is very important. Distal femur cut and the tibial cut. Okay, distal femur cut has predominantly effect on extension gap, exclusively have an effect on extension gap, whereas tibial cut has both flexion as well as extension, right? So this concept is very important. Okay, so with this, whenever we find an FFD knee, so one thing we have to do, adjust with the distal femur cut. Anything else you can think of? Anything else?
Soft tissue release not done. properly.
Soft tissue injury is very important. Okay, what are the soft tissues?
Capsules of the joint capsule and
Yes, it is the capsule. Before moving on to this, first we have to look for osteophytes. What osteophytes? Posterior osteophyte. This is must. Posterior osteophytes, posterior loose bodies. Okay, these loose bodies are partially calcified. Okay, since this partially calcified, this may not appear in the X-ray. Okay, even though if it appears, it will be looks very small. It's like your osteochondroma. The look is small, but the feel is big because of the cartilaginous part, which has not calcified. A bone will appear only, a calcified tissue will appear only in X-ray if it is